We know that stenosis, it's irreversible and progressive condition, and because of the aging. But what adds into it is a congenital and developmental stenosis, which often, is there, and we really need to identify. There are acquired causes and there are combined, and we have to consider the iatrogenic, metabolic, rheumatological conditions and inflammatory conditions as well when we talk as a stenosis as a whole. Considering to the word tandem, the dictionary meaning of the tandem is one after another. But as we know that, in medical science, there are many misnomers, and same way the tandem stenosis is as well. So when there is spinal canal narrowing in two distinct regions, that's where the term used is tandem stenosis. And we have been seeing this MRSS as well, as we know that aging population is increasing. So multi-regional spinal stenosis, we have been seeing it quite frequently as well. And some of them can be symptomatic, some of them can be asymptomatic or severe myelopathy or myeloradiculopathy as well. And that's where the decision making becomes a challenge. And as such, there are no treatment algorithm, which I will share at the end of the presentation. So tandem stenosis, when you have to define, it is the condition which is of two regional stenosis. And usually we have either LMN signs or UMN signs, or even the combination of both. And it was first coined in 1964. 12 patients were sort of described in the literature, but Deggy et al., they were the first one who said that tandem stenosis is something that we should be considering. The incidence in the literature and even the incidence in the general population is 0.12 to 28%. So that's not low at all. And same thing was observed in the cadaveric studies and the radiological studies as well. And the incidence has gone up to 32% as well. So that is something which is not to be neglected. And most important thing is this combination of the classic clinical triad, intermittent claudication, mix upper and lower extremity signs and symptoms. And what we see most of the time is a progressive gait disturbance. And that's what makes it unique in tandem stenosis. So upper motor neuron signs, lower motor neuron signs, and UMN signs will be missed or will be masked by the lower motor neuron, meaning the lumbar compression. So that is something which you may not see classically present as well. Why do we discuss this issue? Because as I said, it is a clinical cheater. Radiologically also it mimics a lot of things. Treatment challenges already exist. Literature, it is not aligned. And that is where we have been sort of giving this awareness even in the DAOS course and the AO spine. I also was one of the chairmen and I conducted this on tandem stenosis, the whole symposia as well. And we shall share about our experience. Coming to a case presentation, 68-year, 2015-16 case, 4-limb numbness, neuric grade 4, and patient had lumbar and cervical stenosis, and we operated both in the same sitting. Patient had DISA, diffuse idiopathic skeletal hyperostosis, and that patient 3 years follow-up was doing well. Similarly, another case, 79-year gentleman, left more than right upper limb shooting pain, neuric grade 5. Also, he had the dribbling of the urine, bladder bowel involved as well. As you can see, there is kyphotic cervical spine. Particularly on the X-ray and MRI, you can see that there are multi-level compression, anterior and even the lumbar compression at L4-5 as well. And we ended up operating him, giving him the kyphotic posture correction. As you can see, the post-operative MRI, which we all the time do for all our myelopathy patients, and patient remained good mobile till patient passed away due to cardiac issue. Another case, both lower limb claudication, both lower limb numbness, spasm, imbalance. This is the case where there is dorsal stenosis along with the lumbar stenosis. So there were signs upper motor neuron because of the D12L1 and the lumbar stenosis as well. So if you do not operate both in the same sitting, that's what we did. We operated both in the same sitting and both had done the TLIF as well. And he did very well at the 1 year follow-up. That's what I have the image taken at that time. Another case where left more than right lower limb radicular pain, disability, but there were no upper limb symptoms. But if you look at the MRI, that is why I have put the mimicker. If you look at the MRI, there is compression, subtle compression at cervical, lower cervical as well. And we ended up operating only the lumbar spine. We did not operate that patient, the cervical spine. So these are the cases where we have to have the, call taken. And what is the literature review? Well, let us come to the dilemma. Proponent of the cervical first, they will say cervical need to be addressed because there is myelopathy. Proponent of the lumbar first, they will say that looking at this Sadhviji, if you operate lumbar, the correction of the deformity and so cervical symptom is likely to disappear. So we have the mix of both. Some says myelopathy first, some says radiculopathy, some says, look at the posture as well. Literature says TSS, the tandem spinal stenosis should be heightened if preoperative symptoms fail to expectedly improve following decompression. But I think nowadays we are out of all these dilemmas because we have the full length screening done practically for all the patients when we operate. This is the beautiful sort of literature review, systemic review 2017 JBJS. And what they have concluded, it is an overlooked disorder. Diagnosis is must and important, and surgeon should plan either single or simultaneous procedure, which we'll talk, and always address myelopathy in priority. That's what they have concluded. And what they want to talk about is the Torg-Parlow ratio. So basically, we need to look at the body and the canal ratio, and that should be the guide for the planning, the management as well. And that is where the congenital narrowing of the spinal canal will come into the picture, which we do see more often than, more frequently than we think of. So we have our share of literature. We published in 2014 our cases as well, retrospective analysis of the procedure done simultaneously for our patients. And this was published in the European Spine Journal. And we had 53 cases, 2 team of the surgeon, and short lasting surgery, single anesthesia, and that reduced the hospital stay. That was our conclusion when we had presented in the European Spine. We also had presented the similar kind of the study in international orthopedics as well, and we had good outcome when we operated both together. Coming to literature, 2-stage conclusion. So people say that you do one after another, second surgery done 2 weeks to 9 months after the first one. But look at the complication when they had the complication. They had few who did not need second surgery, as I had shown that Sadhviji. But a case of cauda equina after ACDF was also observed. And poor prognosticators, they concluded that the long duration of the symptom, which you all know, myelopathy, they don't do well. So that is why often you have to address early as well. Hand function, when it is affected, then also they don't do well. More than 70 with diabetes and smoking. So 2-stage conclusion, they say that one after another, but operate the myelopathy first. Single stage conclusion, potential benefit of the minimal hospital stay and reduced cost. This is the most important in our Indian scenario, which we consider as the primary focus when we operate these patients simultaneously. And psychological gain. The minute you say that you will need second surgery, they will say, oh, no, I do not want to go through the same thing again. So that is where the cost effectiveness also will come into picture. So coming to the same, we just share our experience, treatment algorithm, what we have been practicing at our center, Savia. Whole spine screening is done most of the time. Now, we do it as a routine. If the cervical is symptomatic, then we always operate. But when the cervical is not symptomatic, we always look at the sagittal balance. We evaluate sagittal balance. We go for the full length X-ray standing. UMN signs may be absent due to lumbar stenosis. So we consider that, these are the red flags. If you develop this, then you undergo cervical surgery sooner. And we observe the patient as well. We, write it down, red flags explain, and we write it down on the piece of paper as well. But when it comes to dorsal and lumbar, even the dorsal is asymptomatic. We have been practicing because of the bone scalpel, our neurological, practically it has become zero, the neurological worsening post-dorsal laminectomy. We operate practically, if there is dorsal stenosis with lumbar stenosis, we operate both in the same sitting because we are in the belt of fluorotic area as well. And we do get a lot of dish patients. So our outcome overall is much better when patient comes in neuro grade 1, 2, 3. 4, 5 obviously are a challenge for both us and the patient as well. When it comes to lumbar stenosis, when there is asymptomatic lumbar stenosis, that's what we feel. Then again, coming to the sagittal balance, we always ask in detail history of bladder and bowel, because most of these elderly patients, when they come to us, they will have prostate overlap as well, prostate megaly, and many female, they will have stress incontinence as well. So what we ask, is there any recent change in the bladder and bowel? And we certainly ask for the bladder, bowel, perineal, perianal sensation as well. And more often than not, we put a finger in the rectum as well, just to make sure that it is not a speculous anus. And we certainly ask for the mechanical pain. If the mechanical back pain is there, patient will not get mobilized, and will have the poor outcome as well. So patient demand also is a driving force when we plan the surgery as well in the tandem stenosis cases. Requirement for the single surgery, once usually we go for the physician and anesthetist evaluation. and 2 team of surgeon, 2 set of equipments, and we certainly make sure that the patient's full length, which whatever we want to see, it's on the radiolucent table. So we have an extension which certainly puts everything into the radiolucent area. In our center, the patient preference is usually the single stage surgery. We advise the patient, we explain the patient everything, we mobilize the patient on the second day if there are no dural tears, and we know that, if there is 2 stenosis in the one artery, you have to do both. Similar principle we follow at our center as well. So factors to consider: dish, ankylosing spondylitis, congenital narrow canal, ossified posterior longe ligament, or hypertrophy posterior longe ligament, which is more often seen on the X-ray, and we can do the CT scan to rule out. Other degenerative joint involvement, knee spine syndrome, hip spine syndrome must not be forgotten. We have to address this as well, and whenever we evaluate, we have to consider them as well. With the medical condition, comorbidities, vascular, obviously one will look at, and the obesity and the sagittal balance we should look at as well. We always grade the neurological and radiological grading as well, in order to make sure that whatever level we operate, and we go for the full length MRI. Take home message: we are in the era of earthquake. As Dr. Amarnath said earlier, we are going in the same direction as Caucasian population has been going. We have a lot of aged people in our society, and we should be giving good living to them as well. The severity of the symptom, masking neurology is 1 to 28%. Detailed examination is very important, and MRI often is false positive, 24 to 37% as well. So not necessarily anything that is seen on the MRI we operate, but we certainly have the clinical radiological correlation as well. And age more than 70 will have comorbidity condition as well. Do not treat radiology, as I mentioned earlier. Do warn the patient and relatives, mention the rare flags as well. Simultaneous single procedure, that's what we do, and we have been happy with that. Patient fitness and counseling has to be done, and the bone scalpel has changed the practice as well. And post-op rehab is very important. We had presented this multi-regional spinal stenosis recently in one of our meetings as well in the ASSI, and that is something which we do because we are in the fluorotic belt. So C2 to D12, but laminectomy was done, and it takes about 1.5 hours for us to do, 2 teams working together, and that's what was the thing. So let's go to the pulse of wisdom. That's my last slide. Planning is important. Pre-op evaluation, patient demand has to be considered. Beware of tomophilia. We have been considering, we know that some patient, they will come to us and say, oh, you operated this patient, now he is better, so let me undergo surgery. So this is tomophilia, cut, and you have the philia as well. So they come to us demanding for surgery. So we always place little safe in those patients. Family support plays the major role. So if I have to conclude my 30 years of plus practice, I would say those patients who will do well, those who have good family support, good family backup, and good family care taken care. Positive, very, very important. Positioning is very important. If you have to position this patient properly, and we have to have the experienced staff, coordination of the team is very important. We do not anybody to wake up if you are operating lumbar, and if there is no cervical symptom, you are not operating cervical, but then if patient may wake up with quadriplegia, if the position is not given properly as well. So very important. Operate lower level first if there is dural leak, because then the collapse of the dural sac will make the life difficult. So this is one of the technical things which we often practice as well. So if there is dural CSF leak occurs, which often can occur, then in that case, operate the lower level first, decompression first. Post-op management is very important. Handling should be desired effect. And as I said, complications wise, work begets work, and work begets undesired effects too. Thank you for your patience hearing. Thank you.